phone the patient with a pathology result, please.
In St. George's, we have very strong kidney and bladder cancer service. It has been established now for more than 2 decades.
27mm upper pole tumour.
We have a fantastic team of clinicians, surgeons and nurse specialists who are dedicated to the management and follow-up of patients with bladder and kidney cancer. We are a major teaching hospital in London, and we have a very large catchment area. We serve about 1.3 million people directly and about 2 million people indirectly through our network of hospitals. Royal University Hospital, Epsom and St Heliers Hospital, Queen Mary Hospital, and to a degree Kingston Hospital. And we work in close collaboration with our sister hospital, Royal Marsden. We at St George's believe that we should go to our patients rather than our patients come to us. We go the extra mile to spare our patients doing so.
I've given you my card, haven't I? So
yes.
You can give me a call, leave me a message, or email's usually pretty good.
We strike a long-term relationship with our cancer patients. That ensures that any change in their situations and change in their circumstances are dealt with in timely and suitable fashion.
Bladder cancer, unfortunately, is a dreaded disease, especially if it's high-grade cancer. But many patients also have low-grade cancers. And it's important that not only do you get this right, but also then you're able to present treatment options to the patients. The very low-grade bladder cancer patients only need cystoscopy follow-up. So our role then is to make sure they have their cystoscopies at the appropriate time at the center of their choosing, such as the nearest hospital, a community center nearest them, which means that patients, if they have a problem with worsening bladder cancer, we can then refer them to the central hospital, which is St George's Hospital. What's unique about St George's Hospital's bladder cancer service is there's a whole gamut of services, from hypothermia service, which is the Synergo system, the mitomycin service with that, the BCG, as well as the robotic surgery, as well as open surgery for patients. Patients are therefore aware of the whole gamut of options, which helps them make the most appropriate choice for them. They know that they're given all the choices that are available to them, perhaps nationally in the UK.
Patient treatment plans are generally set out following British NICE and the European Association of Urology guidelines, but because we have a dedicated team of consultants specialising in bladder cancer supported by a nurse specialist, we take into account patient wishes in these treatment plans.
One of the things we're trying to pilot here now is holistic needs assessment, which is a Macmillan project where you complete on the iPad a questionnaire, and that then gives you the opportunity to raise any concerns that you might have, that you might find difficult to raise.
The patient is not just a disease, so we have to look at their family setup, who's supporting them, what concerns they have.
Any concerns about housing or finances?
No.
So we use a tool where we go through a series of questions which can be tailored for a normal conversation, and then we'll find out from that if they've got any financial worries about telling their children about their diagnosis, or worries about the cancer itself.
We do everything in our means to preserve the bladder and ensure that they can live safely with their own bladders for as long as possible. However, at some stage the bladder cannot be retained. Bladder removal surgery is offered, keyhole surgery assisted with the robot, trying to preserve all aspects of their normal life. We offer a bladder substitution options. We could build a new bladders for them using a piece of their small bowel to try and get them back to as normal life as possible.
If they offer you choices, you can think, and you have plenty of time to think when you're having the chemotherapy, because you do change your mind. Every part of treatment I had, they explained what would happen, and I always remained positive, and from the help of all the team, it was, they kept me going, and they were on the end of the phone for me.
Choice is really important, but when there are a variety of options with risks and benefits in each choice, I think they have to be very well counselled and be involved in that choice. And it's really a very mutual decision that we reach before we embark on any particular approach. The options for treating renal cancer really depends on at what stage in the development of that cancer one presents. If one has a very small early stage cancer, one can do surveillance because these are known to grow extremely slowly and there's a very long window of opportunity to treat them. We can do freezing, cryotherapy, and this is also particularly suited to those who are at greater operative risk. And then finally we can cut out the lesions in a partial nephrectomy, which we do with a keyhole approach with robotic surgery. We also can remove the whole kidney, which is a fairly standard approach to any tumor that has reached a particular size. We are extremely motivated to expand the options as new technologies arise. If we are happy that the options are ethical and approved, we're prepared to move our boundaries as well. We are involved in a research program and encourage patients to become involved.
There are a lot of promising changes. There is now new drugs based on chemotherapy to treat bladder cancer. This is likely to develop and become available to more patients as time goes on. Having the robot at St. George's makes surgical treatment more versatile. I offer bladder removal surgery for patients above the age of 80 on a regular basis. 10 years ago, these patients were automatically excluded from such a surgery because it's a major surgery. So things are moving and we always aspire for better, but we are here to continue with our patients and serve them as well as possible.